consultant. Currently I am staying in Agartala. I am working in a corporate setup. So today, I want to thank ISCCM first, so that we are having an excellent platform for our nursing students, so that they can be trained and the teaching process can be done in such a smooth manner via our live classes and sessions. So our topic of presentation today is basics of ABG analysis, which will be presented today by Dr. Monalisa Mishra. Dr. Mishra is currently working as a consultant and ICU in charge in Utkal Hospital, Bhubaneswar. After passing her MD anesthesia, she has done FNB in critical care medicine from Gangaram, New Delhi. And she has now almost 8 years of experience in critical care medicine. She has multiple publications in national and international journals as well. And she has appeared in more than 20 guest lectures in state, national, and international forums. Her area of interest is research and building robust nursing training and teaching programs in India, especially in ECMO, CRRTs, etc. So without further ado, I welcome Dr. Monalisa Mishra to present the topic today, which is basics of ABG analysis for nurses.
Thank you, Dr. Paramita, for that kind introduction. So without further delay, I'll start my presentation. You're able to see my screen?
Yes, ma'am, it is visible.
Yes, okay, thank you. So I'll start. So today we are going to talk about ABG. ABG is a very important topic for nurses, doctors, trainee nurses, for everybody. So ABG, as you all know, we do on an everyday basis for various reasons. The various components of ABG are pH, PCO2, PO2, bicarb, oxygen saturation, and base excess. And we all know what are the desired values. So pH normal range being 7.35 to 7.45, PCO2 4.5 to 6, PO2 10.5 to 13 kilopascals. This is all given in kilopascals, but you all know the millimeters of mercury also. The PO2 will be around 70 to 100 millimeters of mercury. PCO2 will be around 35 to 45 millimeters of mercury. Bicarb is 21 to 27. Oxygen saturation is 95 to 100, and base excess also plus or minus 2. So these are the normal components of ABG. So ABG, as we all know, why is it important? Acid-base balance of our body. The normal pH is 7.35 to 7.45. Less than that will be acidosis, and more than that will be alkalosis. So acid-base balance of the body, if you want to see, the body produces acids daily. It around produces 15,000 millimoles of carbon dioxide and 50 to 100 milliequivalents of non-volatile acids. And the main responsibility of getting rid of this is the lungs and the kidneys. So the lungs and the kidneys attempt to maintain the balance, and some amount of buffering also occurs in the liver. But the main two organs that are responsible to maintain acid-base balance are the lungs and the kidneys. Okay, so the two things which you have to keep in mind for the next 45 minutes while we are going through the ABG class also, because then only you'll be able to understand the ABG, understand why pH is acidotic and how is the body compensating for it. So this is very important. The two important organs of our body, how they act in actually maintaining the acid-base balance of the body. So what are the indications of doing ABG? So there are multiple indications of doing ABG in ICU. As you all know, you want to identify if there is anything wrong, acid-base balance that is going on in your body, to measure the PO2 or PCO2 of your body, to assist the response to any therapeutic interventions. For instance, if your patient is coming to you with metabolic acidosis and it's a diabetic patient, it could be diabetic ketoacidosis. So if you're giving insulin to the patient and you're assessing the response to insulin, if the acidosis is getting better. Also, you can see carboxyhemoglobin and methhemoglobin hemoglobin levels in the ABG. It comes like COHB, which you can see in your ABG. And also in case of emergency acute settings, you're not able to find a venous sample and it is just easier to find an arterial sample. That is another reason for doing ABG. But the major reasons why you do ABG is all the sick patients in the morning, you do ABG to identify if there is any acid-base disturbances, let it be CKD patients, let it be COPD patients, to see the PO2 of the patient, to see the PCO2 of the patient, and to do to see the response to your therapeutic interventions. So these are the indications of doing ABG. But what is important for you to know also is that there are a lot of contraindications for doing ABG as well. For instance, that if the patient is having an abnormal Allen's test, which I will tell you in the next slide, what is an abnormal Allen's test. If there is any local infection at the puncture site, then you'll not be able to puncture to take an ABG. If there is any distorted anatomy because of previous surgeries or any malformations or burns, or if there is any AV fistula, for instance, it's a CKD patient who is undergoing dialysis, sometimes they have a fistula. If you have a fistula, you can't take ABG from that side, right? And this, there is any peripheral vascular disease of the limb also. So these are the various absolute contraindications of taking ABG from that particular blood vessel. There are some relative contraindication also. For instance, if the patient is having severe coagulopathy, or if the patient is on heparin, warfarin, or any of these drugs, not aspirin, but other drugs, then use of thrombolytic agents. If the patient was thrombolized because of a CVA, or patient was thrombolized because of pulmonary embolism, then for 24 to 48 hours, we avoid taking ABGs. So these are the contraindications of not doing ABG. Avoid doing ABG in these certain situations. So we all know what is the preferred site of ABG. So everybody finds it the most safest and easiest to do it from the radial artery. Please remember that. This is the first choice always. And if radial artery is not possible for any reason, then you go for, femoral artery, which could be the second choice. But, you have to be very careful in taking a sample from femoral artery. You have to make sure that you have adequately giving pressure for adequate amount of time so that there is no hematoma which is formed. So radial artery, you usually use a 45-degree insertion angle. Brachial artery, you use 60 to 90-degree insertion angle. Femoral artery, you use 90 degrees insertion angle. Sometimes you use the dorsalis PDS arteries also, and rarely use the posterior tibial artery also. So if you all practice ABG every day in your ICU, you know that the first choice is always radial artery. And if there is any reason why you're not able to take a radial pulse, you're not able to feel a radial pulse, sometimes the patient is very hypotensive, then you might not be able to feel the radial pulse, then you go for femoral pulse. But be very careful while taking a femoral sample, because first of all, that is a very difficult site to stop bleeding if there is hematoma. So you have to make sure that there is adequate pressure that is given. So these are the sites of taking. Now equipment. Equipment, we all know we have to wear gloves, right? Then we need some syringe for sampling. Then we require a needle to puncture the artery. You require some antiseptic solution to clean the area. You require an alcohol swab, ABG syringe, gauze piece, adhesive bandage, a sharp object container, and lignocaine if you're going to give local anesthetic before taking ABG. So this is your equipment list. Now we'll just see a small 2-minute video to understand what ABG, what are the important things you have to remember. So always remember to wash your hands. Always, if the patient is conscious, introduce yourself and always tell what you're going to do. Confirm the patient details. That is number one, that this is the patient you want to take the ABG from. And then you explain the procedure, that what you're going to do. And after that, if the patient is conscious, you have to gain consent. Check for indications and contraindications. Do you actually need the ABG? And what are the contraindications you need to be aware of before taking an ABG? If the patient is on warfarin, if the patient is on heparin, you have to ask those questions. Then you have to gather all the equipments, your gloves, gauze piece, local anesthetic, alcohol swab, tape, alcohol wipe, ABG needle. Then you have to perform modified Allen's test, which we'll discuss what it is. So you have to ask the patient to clench their fist tightly. And after that, you have to apply pressure to both radius and ulnar artery. As you can see in the video, the person is applying pressure to both radial and ulnar artery. And now you see that the hand has become white. Now, when you release the pressure of the ulnar artery, you see the color is returning to the hand in 5 to 15 seconds with adequate ulnar blood supply. Similarly, you have to palpate the radial pulse also, assess its scores. Clean the sites for 30 seconds and then allow it to dry. Wash your hands. Make sure you sanitize your hands. Wear your gloves. This is a heparinized syringe. You insert the needle at 45 degrees. You observe the flashback of blood that is coming, and that is showing that it's a radial, it's an arterial sample. Once you get your sample, you remove and then apply firm pressure. Okay, so we are done with this video. Just exit. Yeah. So this is how you do your ABG, just a video to show how it is done. Then a small video for Allen's test. We just went through it, but quickly in a minute, if we can just see what is modified Allen's test, so that you're sure that you're not, missing this step. So there are two arteries you're going to supply the dorsum of your hand, that is your radial artery and your ulnar artery. So you have to make sure that both radial artery and ulnar artery are patent before you take an ABG sample. So for that, you have to occlude both the radial artery and the ulnar artery simultaneously. Ask the patient to open and close the fist repeatedly. And once it is occluded, as you can see that there is a whiteout. And now you release the pressure from the ulnar artery and see in 15-20 seconds, the hand is going to become red again. So this is how you do your modified Allen's test. So as you made sure that both the radius and the ulnar artery are patent, then you can go ahead with your ABG sampling. Now, what are the steps in ABG analysis? We'll move to the next part of the presentation. So first will be for finding out what is the pH. Is it acidotic or alkalotic? Next will be what is your primary disorder. Then you have to calculate if there is adequate compensation. Then you have to calculate if the compensation is acute or chronic. And then check if there is any anion gap. And if there is an anion gap, then you check the delta gap. And then what is the differentials of your clinical process. So interpreting your ABG, as we all know what are the normal values. Normal range will be 80 to 100 of PO2. pH will be 7.35 to 7.45. Respiratory component, normal range is 35 to 45 PCO2. Metabolic component, normal is 22 to 26 millimoles per liter. And normal lactate level will be less than 2 millimoles per liter. Anion gap is sodium plus chloride plus bicarb. And normal, sodium minus chloride plus bicarb, and normal anion gap is 8 to 16 millimoles per liter. And also corrected anion gap is very important. For every 1 gram per deciliter decrease in albumin, the anion gap will decrease by 2.5 millimoles. And then calculating the delta gap, that is change in anion gap divided by change in bicarbonate. So this will become more clear with an example as we move forward. So there's just some points you have to remember while you have taken an ABG sample, that you have to process the sample immediately. Okay, why you should process the sample immediately? What happens if there is delayed analysis? So the oxygen which is there in the ABG sample will get consumed, and the CO2 of production will continue after the blood is drawn. So if it is an iced sample, it will maintain value for 1 or 2 hours only. And if it is an uniced sample, it becomes invalid in 15 to 20 minutes. So PCO2 increases 3 to 10 millimoles, millimeters of mercury every hour, and PO2 decreases. And also pH decreases because lactic acidosis is taking place because of the glycolysis in the RBCs. So this is the reason you have to immediately process your sample. Please remember, you cannot wait for more than 1 hour if it is an ice sample, and if it's an uniced sample, you have to process it within 5 to 10 minutes only. Okay. And what is the effect of temperature change on ABG value? So for every change in like temperature of 0.01, the pH decreases. Okay, so for every change in CO2, if increase in CO2 also, the pH will actually decrease. So you have to keep this in mind also while analyzing the ABG. The next thing you have to keep in mind is most of the ABG analyzers actually report the data at normal body temperature. So if there is severe hyper or hypothermia, the value of pH and PCO2 at 37 degrees can be significantly different from the patient's actual values. And the changes in PO2 values with temperatures are also predictable. How do you find out? So if you subtract 5 millimeters of mercury of PO2 and 2 millimeters of CO2, add 0.012 pH per 1 degree decrease in temperature. So this is a usual calculation. It's a rough calculation of how you actually find out the temperature difference on the ABG. And what about an air bubble? So if there is air bubble, then what happens is, it leads to increase in PO2 and decrease in PCO2. This is what you have to remember. So how do you avoid an air bubble? You have to draw the sample very slowly and preferably in a glass syringe. Okay. And steady state sampling should be done during steady state after the change in oxygen therapy or a ventilatory parameter after 3 to 10 minutes. So suppose you have changed any ventilatory parameters, like you have increased the PO2, you have increased the FiO2 in the ventilator, you have changed the tidal volume, you have changed any ventilatory settings. Preferably, you have to wait for at least 10 minutes before doing the ABG, because then only you'll achieve the steady state. And remember, in case of air bubble, you have to draw the sample very slowly. And what happens if there is an air bubble? Your PO2 will show more and PCO2 will show less. Okay. And what happens if there is leukocytosis? What is leukocytosis? Excess of WBCs. If there is excess of WBCs of the patient is having leukocytosis, then if the pH decreases and PO2 also decreases and PCO2 increases. So for 0.1 ml of O2 consumed in the blood in 10 minutes in patients with normal TLC, so marked increase in patients with high TLC and platelet count, hence we require immediate chilling and analysis. So leukocytosis also causes decrease in pH and PCO2 and increase in PCO2. And what happens if there is excess of heparin? If there is excess of heparin also, it causes decrease in bicarb and PaCO2. Only 0.05 ml of heparin is actually required for 1 ml of blood. Okay, so only 0.05 ml of heparin is required for 1 ml of blood of ABG analysis. Please remember that. So syringe can be emptied of heparin after flushing, or only dead space volume is sufficient, or dry heparin should be used. Okay, now we'll go how to analyze your ABG. Now for ABG, 5 steps are most important. One is finding what is a comprehensive history and physical examination, because you have to always correlate it with the ABG of the patient. Simultaneously perform the ABG and serum electrolytes so that you can match the values of the electrolytes on the ABG and serum electrolytes. Identification of the dominant disorder. Then you have to calculate the compensation. Then you have to calculate the anion gap and all the other gaps. Okay, so we'll go step by step and we'll make it even clear with an example. So while reading an ABG, first always you see the pH. Either the pH is normal or high, then it is alkalosis or alkalemia, or it is low, then it is acidosis or acidemia. Now, after that, this is the primary process. You have to find out what is the primary process, if it is alkalosis or if it is acidosis. After that, you have to find out what is the dominant disorder. Is it a respiratory acidosis or a metabolic acidosis, or is it a respiratory alkalosis or a metabolic alkalosis? So if it is high PCO2, then it is respiratory acidosis. If it is low bicarb, then it is metabolic acidosis. And similarly, in case of alkalosis, if it is low PCO2, then it is respiratory alkalosis. And if it is high bicarb, then it is metabolic alkalosis. First, this step is very important. You have to identify what is the primary disorder. After you have identified what is the primary process, you have to calculate the compensation. Always remember the compensation is opposite. So if it is respiratory acidosis, the compensation will be metabolic alkalosis. If it is metabolic acidosis, the compensation will be respiratory alkalosis. If it is respiratory alkalosis, the compensation again will be opposite, metabolic acidosis. And if it is metabolic alkalosis, the compensation will be respiratory acidosis. So that is what you have to remember. You have to know that whatever is the primary process, the compensation will be totally opposite of that. Okay. So first you have to check what is the validity of your ABG, if your ABG is valid also or not. Sometimes what happens that you take a sample, but your ABG is not matching with the patient ABG. Like, okay, this patient cannot be so acidotic or this patient cannot be so alkalotic. So always check the validity of the ABG. This is always the first step. How do you check the validity of the ABG? You have to find out what is your H plus ions. H plus will be equal to 24 into PCO2 divided by bicarb. Okay, so whatever is this value will be your H plus. And according to that, if you have this table handy, this is available in internet, this is available in your QMD calc, this is available everywhere. So you just have to, according to whatever is your H plus ion, you have to find out what is your pH. For instance, if your H plus came to be 40, your pH will be 7.4. If it is 35, then it will be 7.45. So this is how you have to see if your ABG is valid or not. Only when the ABG is valid, you have to move ahead and calculate the further steps, right? Now, next is identification of the dominant disorder. This we already went through. If the pH is low, bicarb is low, okay, then it is metabolic acidosis. That is your primary disorder. Okay, if the pH is high, bicarb is high, then it is metabolic alkalosis. If the pH is low and the CO2 is high, then it is respiratory acidosis. And if the pH is high and the CO2 is low, then it is respiratory alkalosis. So this is the way you find out what is the dominant disorder. That is the first step. Please don't forget this. Okay, that you have to know how you find out what is the dominant primary disorder. Then only you can calculate what is the compensation and move ahead. And always your dominant disorder has to match clinically with the clinical status of the patient, history of the patient, physical examination of the patient. We will tell you how in the future, in the further slides, but this is how you calculate, you know what is the dominant disorder. That is the most important step. Okay, now first step, you have calculated the dominant disorder. So this is how you find out. Metabolic acidosis means pH is low, bicarb is low. Metabolic alkalosis means pH is high, bicarb is high. If it's respiratory acidosis, pH is low and CO2 is high. If it's respiratory alkalosis, pH is high and CO2 is low. So this is how you find out what is the primary disorder. After finding out what is the primary disorder, you calculate the compensation. Now, you don't have to remember this compensation formulas whatsoever, no need. You have it on all the textbooks, you can use it and calculate. So if it is metabolic acidosis, what we said, that the compensation will be respiratory alkalosis, right? So you have to calculate how much is the respiratory alkalosis that is taking place and is the compensation adequate or not. For instance, in case of metabolic acidosis, try to understand step by step, your pH will be low. And what is your primary change? Your bicarb will be low, right? So this is your metabolic acidosis. In order to compensate for this low bicarb and low pH, the body compensates by a compensatory response of reducing CO2. That is respiratory alkalosis. The opposite of metabolic acidosis will be respiratory alkalosis. Now, what you have to calculate is the compensation adequate or not? How do you calculate that? What is delta PCO2? That is a change in PCO2. Suppose the normal PCO2 is 45, right? We all know the normal PCO2 is around 35 to 45, so 40 for calculation purposes. And patient's PCO2 is around 30. So the change is what? 40 minus 30, 10. So if that is equal to 1.5 into change in bicarb. So how much will be the change in bicarb? That also we'll understand from an example. 24 will be a normal bicarb and let the patient's bicarb be 10. So you have to calculate from this formula that the change in PCO2 is equal to 1.5 into change in bicarb. Okay, this is how you calculate the metabolic acidosis formula. Okay. Similarly, in metabolic alkalosis, this is the formula. The change in PCO2 will be equal to 0.7 into change in bicarb. Similarly, in respiratory acidosis, you calculate. So what happens in respiratory acidosis? The primary change will be increase in CO2. And how does the body compensate for that? It compensates by increasing the bicarb. That is metabolic alkalosis. So compensatory response for respiratory acidosis will be metabolic alkalosis. So how do you calculate if the metabolic alkalosis is adequate or not? That is the delta bicarb will be equal to 0.1 into PCO2. And if it is a chronic respiratory acidosis, it is 0.4 into PCO2. So similarly, in case of respiratory alkalosis also. So if the PCO2 is actually low, your bicarb will also become low because the compensation is metabolic acidosis. And then you calculate it like this. This is a formula. So I'm sure this will be a little confusing for you at this stage. So when we do examples, lots of examples, and it will become very clear for you. So this is the compensation formula you just remember for now. Then the next step will be to find out if the compensation is adequate or not. Okay. How do you calculate that? If it is a metabolic disorder, you have to measure the expected PCO2. If it's a respiratory disorder, you have to measure the expected bicarb. And then you find out if the compensation was adequate or not. That if it's a primary respiratory acidosis, that will have increase in PCO2 and decrease in pH, and compensation will occur. So always remember the two organs which we discussed, right? There are the lungs and there are the kidneys. So if the lungs is causing the problem, the CO2 is retaining because the lungs is not able to wash out CO2, then the compensation will be done by kidneys. How the kidneys will compensate? For respiratory acidosis, the kidney will compensate by doing metabolic alkalosis by increasing the bicarb in the body. So this is how. So when your lungs are at fault, the kidneys try to compensate. When the kidneys are at fault, the lungs will try to compensate. So this is how your body is trying to compensate for one organ, or the other organ is trying to compensate for the other. So if it is respiratory acidosis, the kidneys will compensate by causing metabolic alkalosis. If it is metabolic acidosis, the lungs will compensate by causing respiratory alkalosis. So this is how you have to know if the compensation is adequate or not. So this is a compensation formula as we studied right now. You just have to see delta PCO2 is equal to 1.5 into delta bicarb. Similarly, for alkalosis, the delta PCO2 will be 0.7 into delta bicarb. This is a simplified formula. This also you will understand when we talk about an example next. Let's go to the example. So this is the formula which we actually learned about. PCO2 is equal to 1.5 into bicarb plus 8 plus or minus 2 for metabolic alkalosis. For every 10 increase in bicarb, PCO2 increases by 6. Again, once you do a example, you will understand slowly. Now you have to check the compensation in case of respiratory acidosis. So you have to see in case of bicarb increases by 1 for every 10 millimeters of mercury increase in PCO2, and bicarb increases by 3 for every 10 millimeters of mercury increase in PCO2. In case of acute and chronic respiratory acidosis. Similarly, in case of acute and chronic respiratory alkalosis, the bicarb decreases by 2 for every 10 millimeters drop in PCO2, and bicarb decreases by 5 for every 10 millimeters drop in PCO2 from 40. So this is how you check the compensation. Don't worry about it right now. Right now, we're just going through the theory part of it, and then we will solve the example step by step. The next step will be calculating anion gap. Anion gap will be all the positive ions minus the negative ions in the body. So positive ion is sodium, okay, minus chloride plus bicarb. That is the anion gap. And normal anion gap is around 8 to 12. Okay, if it is more than 12, then it is high anion gap metabolic acidosis. So in case of metabolic acidosis, we usually calculate the anion gap, and on basis of anion gap, we divide it into two. Either it is high anion gap metabolic acidosis or normal anion gap metabolic acidosis. So anion gap is sodium minus chloride plus bicarb. It is used for evaluation of metabolic acidosis. The normal is around 4 to 12. Okay, it depends upon the serum phosphate and serum albumin concentration. You have to correct the anion gap depending upon the albumin also. So for every 1 gram per deciliter decrease in albumin, your anion gap will decrease by 0.25. Okay, and depending on that, your acidosis is actually classified into high anion gap metabolic acidosis and normal anion gap metabolic acidosis. We'll read about it in a little bit of detail. After that, now the last step of ABG, after that we'll go to the examples. So after the last, calculating the gaps. What are the other gaps? So you have anion gap, right? After that, you calculate what is the delta anion gap. Delta anion gap means anion gap minus 12. Okay, and you calculate what is delta bicarb also. That is 24 minus bicarb. That is change in bicarb. So why do you calculate that? If delta anion gap is equal to delta bicarb, then it is only high anion gap metabolic acidosis. But if delta anion gap is more than delta bicarb, then it is high anion gap metabolic acidosis, but there might be some component of metabolic alkalosis also. And if anion gap, delta anion gap is less than delta bicarb, then it is high anion gap metabolic acidosis along with some normal anion gap metabolic acidosis. This step will also become clear to you after an example. So this is what you have to remember. Now we'll go to the case. Okay, we'll slowly solve some cases so that this becomes clear. Now there's a 70-year-old lady who actually came to you with a history of ventral hernia repair. And with a mesh, the patient was admitted to you with small bowel obstruction. They required serial examinations. NG tube was put in, IV hydration was given, and electrolyte correction was given. During the next 24 hours, her pain worsens, and there was severe, significant bilious drainage from the NG tube. Okay. So these are the lab reports. Sodium, potassium, chloride, bicarb, and this is your urea creatinine, your calcium, albumin. So, and this is your ABG, pH 7.5, PCO2 24, PO2 90, bicarb 17. So what is the most likely diagnosis in this? Anybody wants to answer? Can they answer at this point, or should I continue with telling the answer? So I'll just continue telling the answer, and then when we discuss questions, then you guys can answer. So this first step will be actually finding out what is the primary main disorder, right? The dominant disorder. So as you all know, this is alkalosis, right? pH is more than 7.5. So it is alkalosis. So the first step is that to find out that this is alkalosis. So ABG is this. Step 1 is, of course, to find out if the ABG is valid or not, as we discussed. So the bicarb will be 24 into 24 by 17, 33.8. It is actually valid only. Step 1, finding out if it is alkalosis or acidosis. So as we all know, this is alkalosis, pH is 7.5. Next step is to find out if it is respiratory alkalosis or metabolic alkalosis. So as you can see, the bicarb is low and the PCO2 is low as well. So it is respiratory alkalosis. Normal PCO2 is 35 to 45, right? So the PCO2 is low. So it is respiratory alkalosis. Next, you have to find out if it's acute or chronic. So for acute respiratory alkalosis, the formula which we read, that is pH, that is 7.4 plus 0.08 into fall in PCO2. Fall in PCO2 was 40 minus 24, that is 16. So it is 7.52. So it is acute respiratory alkalosis. For chronic respiratory alkalosis, the formula is different. You don't have to remember these formulas. They are available in the internet. So you have to just calculate what is if it is acute or chronic respiratory alkalosis. So as you saw that because the pH is 7.52, if it is acute, so it is more close to acute respiratory alkalosis. So the primary diagnosis here is acute respiratory alkalosis. Okay. So after finding out if it is respiratory, if the primary disorder is alkalosis, okay, we have to see. So this is how you calculated if the ABG was valid or not. So as your bicarb was 33 so H plus was 33.8. So it is somewhere between this. So the pH will be 7.5 to 7.55 and it is 7.5. So it is valid. And after that, you found out that it is respiratory alkalosis. After finding out respiratory alkalosis, you have to see if there is metabolic compensation or not. So the formula was this. So for acute respiratory alkalosis, there should be a drop in bicarb by 2 for every change in PCO2 by 10. Okay, so PCO2 is 16. So bicarb according to that should be 21. And here the bicarb is 17. So it is additional metabolic acidosis along with respiratory alkalosis. So the compensation is not taking place here. It is metabolic acidosis additional along with the respiratory alkalosis that is present. So if you see this, the whole thing, that is the bicarb, the sodium, potassium, the chloride, the bicarb. Then you calculate the anion gap also. So if you calculate the anion gap, the sodium minus chloride plus bicarb, that is 27. So it will be high anion gap metabolic alkalosis. Okay. So, and then the last step will be calculating the delta gap. That is a delta anion gap, that is 12 minus 27 minus 12 divided by the delta bicarb. That is 24 minus 17. So that is equal to 1. So then this must be, if it is equal to 1, so this must be some additional metabolic alkalosis as also. So if you look in the whole diagnosis, your diagnosis will be patient has a mixed acid-base disorder. So it will be metabolic acidosis is definitely there. Along with that, metabolic alkalosis is there. And along with that, respiratory alkalosis is also there. So there are 3 disorders which are actually occurring at the same time. So to find out what are the causes of metabolic acidosis, we have high anion gap metabolic acidosis and normal anion gap metabolic acidosis. So for high anion gap metabolic acidosis, this is your mnemonic mud piles. And for non-anion gap metabolic acidosis, this is your mnemonic. So these are the various causes of metabolic acidosis which you see on day-to-day practice. So what are the symptoms of metabolic acidosis? If you want to see, the symptoms of metabolic acidosis will be headache, decreased BP, hyperkalemia, muscle twitching, warm flushed skin because of vasodilation, nausea, vomiting, diarrhea, change in level of consciousness is there. Then rapid breathing is there, compensatory hyperventilation, and these are the common causes. Diabetic ketoacidosis, severe diarrhea, renal failure, shock. So these are the various causes of metabolic acidosis you encounter in your ICU. So there is decrease in ability of the kidney to excrete the acid. So that is why metabolic acidosis takes place. Okay. Now next case. So you can, I think, answer your questions and answer in chat. So 57-year-old man is presented to you with diabetes, with severe abdominal pain. Ketone bodies are detected in urine. So there is a clue in the history itself. Then you establish the IV axis and start hydration. The ABG is this. So what is the primary disorder here? Anybody wants to write the answer in the chat? pH is 7.12. So just identify if what is a primary disorder. Is it respiratory, metabolic, or is it acidosis or alkalosis? What is it? Anybody wants to answer this? Okay, so it's somebody's telling metabolic acidosis. Any other different answer you guys have? Or is it metabolic acidosis only? So I think everybody is agreeing that this is metabolic acidosis only because pH is low. This is acidosis and bicarb is also low. So this is definitely metabolic acidosis. Can anybody tell what is the diagnosis of the patient here? Why will the patient have metabolic acidosis? The clue is there in the history only. Anybody wants to guess? So as I'll tell you the answer. So as it is, somebody has said kidney failure. So it is a diabetic patient who is coming to you with severe abdominal pain and also their ketone bodies in the urine. So we just studied that one of the most important causes of metabolic acidosis is diabetic ketoacidosis. So this is the diagnosis here is the diabetic ketoacidosis. Okay. So diabetic ketoacidosis can cause metabolic acidosis, and that too it causes high anion gap metabolic acidosis. So as you all identify the first step that the primary disorder is metabolic acidosis. Okay, this is clear. So step one is always identifying if it is acidosis or alkalosis. Everybody identify it as acidosis. Then the step two will be identifying if it is metabolic or respiratory, because the bicarb is low here. That is why it is metabolic acidosis. You all identified this. Very good. Now you have to find out what is the compensation. So as we all read, that opposite of metabolic acidosis is what? Respiratory alkalosis. So you have to see if respiratory compensation is adequate or not. So metabolic acidosis, who is at fault? The kidney is at fault. And who is compensating for it? The lungs will be compensating for it. So you have to see if the respiratory compensation is adequate or not. So for that, we have this Winter's formula, which we studied, right? So PCO2 is equal to 1.5 into bicarb plus 8 plus or minus 2. Again, please don't remember the formula. You have it in the internet. So if you put in the numbers there, 1.5 into bicarb is 17 plus 8 plus or minus 2, 33 plus or minus 2. So this should be your PCO2. Okay. But the actual PCO2 is 40, which is too high given the level of acidosis. So if you see there is metabolic acidosis, but the body is not able to compensate by washing out CO2. Because your CO2, if you calculate compensation by using the formula which we studied, the CO2 should be 33.5 or 31.5 or 35.5. The range should be that. But the CO2 is 40, which is telling that the body is not able to compensate for it. Therefore, there is, along with the metabolic acidosis, there is respiratory acidosis present. There is no respiratory compensation or respiratory alkalosis here. So there is, along with metabolic acidosis, there is respiratory acidosis present. And next step will be calculating the anion gap. So you all know how to calculate the anion gap. Sodium minus chloride plus bicarb. So sodium is 145 here minus chloride. Chloride is 95 here plus bicarb is 17 here, right? So that is 33. And what is the normal anion gap? 8 to 12 or 4 to 12. So it is high anion gap metabolic acidosis. This much is clear to everybody. Okay. So this is how you calculate. First, find out it is acidosis or alkalosis. Then find out if it's metabolic or respiratory. Then find out if there is compensation or not. And whatever formula we have learned today, don't remember that formula. You'll have the presentation with you. You can always see the formula and calculate. After calculating the formula, you can decide if the compensation is taking place or not. If it is metabolic acidosis, you have to take the additional step of seeing that, that is high anion gap or normal anion gap by calculating the anion gap. Anion gap is nothing but positive ions minus negative ions. So positive ion is sodium, sodium minus chloride plus bicarb. And the normal anion gap is 8 to 12. If it is high, then it is high anion gap metabolic acidosis. So this is how you have to, interpret your EBG. Simple. This is how you have to go step by step, not go in a hurry and interpret each and every step. So till now, this is okay. High anion gap metabolic acidosis. Now, anion gap, you have to always look into it after calculating what is the albumin level. Because when the albumin is low, anion gap can be falsely low. So how do you calculate the albumin levels corrected anion gap? So albumin corrected anion gap, that means the actual corrected anion gap is equal to the observed anion gap plus plus 2.5 into normal albumin minus observed albumin. We'll give an example. Like in this case, you calculated the anion gap as 33, right? So 33 plus 2.5 into normal albumin is 4 minus observed albumin. Patient's albumin was 2.5. So 36.75 will be the actual anion gap. It's different from 33, right? Not very different, but it is different. So this is you calculate the corrected anion gap. That's all. So that's all you have to know to actually calculate the ABG. And then last step was the delta gap, what we read about. That is the delta anion gap divided by delta bicarb. So delta anion gap was what? Delta anion gap is 36.75 minus 12 divided by delta bicarb 24 minus 17. So 3.5. So if it is more than 1, then there might be some metabolic alkalosis that is present. So that is why you have to see that this whole thing is high anion gap metabolic acidosis, which we calculated. Then there is respiratory acidosis because respiratory compensation is not taking place. And because with the delta gap, you find out that there is metabolic alkalosis as well. So there are 3 disorders which are actually present in this one patient. Okay. Now we'll go to a bit more simpler example. So these are the various symptoms of metabolic alkalosis: confusions, arrhythmias, compensatory hypoventilation, and anxiety, seizures, nausea, vomiting. So these are the various symptoms of metabolic alkalosis. The pH can be high, the bicarb can be high. Okay, so this is the problem with metabolic alkalosis. Now we'll go to a little a simpler case, which has not so many associated disorder. So if it is a 70-year-old gentleman who is presenting to the hospital with wheeze and breathlessness. Okay, so look at the history of the patient. Patient is presenting to you with wheeze and breathlessness. Patient has cough with purulent secretions and fever with drowsiness. He's a smoker also for 25 years. Okay, on examination, you see that he's tachycardic and the chest X-ray lungs are hyperinflated with a tubular heart. Okay, so what could be the history? What is the diagnosis in this case? So thoda bahut you can be clear with the diagnosis itself from the history of the patient. Okay, so this is your ABG, pH, PCO2, bicarb, PO2, electrolytes. So what is the acid-base abnormality? What is the primary acid-base abnormality here? If anybody wants to message in the chat. What is the primary dominant disorder? Anybody? Okay, so here you see there is pH is 7.3. So normal pH is 7.35 to 7.45. So here it is 7.3, then it is acidosis, right? And what acidosis will it be? The CO2 is high and the bicarb is also high. So it is respiratory acidosis. Okay, so it is respiratory acidosis. And if you see, you've been given the serum electrolytes also, because you can calculate further steps. So the dominant disorder is respiratory acidosis. And if you calculate what is the compensation, so you have to see what is the change in the delta bicarb. Again, you don't have to remember the formula. It is equal to 0.4 into delta CO2. Delta CO2 means a change in CO2. Normal CO2, we take 40. So 40 minus 60 will be 20. So 0.4 into PCO2, that is 20, that is 32. And if you see what is the bicarb here, 28. So the compensation is inappropriate or it is not complete, right? So this is how you have to calculate the primary disorder and then the compensation formula if the compensation is adequate or not. And then you have to calculate what is the anion gap. So anion gap, as we said, it is sodium minus chloride plus bicarb. So this is sodium 138 minus chloride, that is 98 plus bicarb is 10. So anion gap is normal. So this is how you calculate the various steps in ABG. So the final diagnosis will be respiratory acidosis, but inappropriate metabolic compensation. Now we'll go to the next case. This is also a simple case. So as we now we are doing only 1 or 2 disorder together. It's a 20-year-old girl who is presenting with difficulty with breathing and upper abdominal pain for the past 1 hour. On examination, if you see the vitals are normal, she's hyperventilating. And on examination, she's absolutely normal. You did an ABG, you saw this. So what is the primary disorder here? What is the dominant disorder here? So as you can see, the pH is high, 7.5, right? So it is alkalosis. That is number one. Number two, you have to see if it is respiratory alkalosis or metabolic alkalosis. As you can see, the CO2 is actually low, right? So it is respiratory alkalosis. Respiratory alkalosis. Okay, and then you have to see if the compensation is taking place or not. Okay, so for that, you have to again use the formula. So the dominant disorder here is respiratory alkalosis. Very good. I think most of you actually got this right also. Then the compensation, you can put this formula. Okay, that is a change in bicarb is equal to 0.2 into change in PCO2. So what was the change in PCO2? 25 minus 40, that is 15. Okay, so 0.2 into 40 minus 40 minus 25, that is 15, that is 3. And change in bicarb means 24 minus 3, that is 21. So compensation is exact, it is adequate. Okay, you can also calculate the anion gap, that is sodium minus chloride plus bicarb. Anion gap is slightly high, which can be seen in respiratory alkalosis. So the final diagnosis here is respiratory alkalosis, only that, because the compensation is adequate. You can also tell that it is respiratory alkalosis with adequate metabolic compensation. That is also another way of answering it. Okay, so this is a simple acid-base disorder. You found out if it was alkalosis, then you found out it was respiratory alkalosis. Then you calculated the compensation using the formula, and then you found out that the compensation is adequate. So you can tell the diagnosis that it is respiratory alkalosis. Okay, so just a quick revision before we end this presentation. Always find out what is the pH first. pH, if it is more than 7.4, it is alkalosis, or less than 7.4, it is acidosis. And then you have to find out what is PCO2. If PCO2 is high, it's respiratory acidosis. If its PCO2 is low, it is respiratory alkalosis. And then you have to see what is the metabolic compensation. This is the formula. I've again written it down so that you can just look into it and calculate. You don't have to remember. Then you have to see what is the bicarb. That is the third step. If the bicarb is high, it is metabolic alkalosis. And if it is low, it is metabolic acidosis. And then you have to calculate the anion gap. Okay, anion gap is sodium minus chloride plus bicarb. Okay, so that is, and expected anion gap is 2.5 into albumin. Then after that, after you found out if it is metabolic acidosis, metabolic alkalosis, you calculate the respiratory compensation again by using the formula. And after that, you calculate the anion gap, and then you calculate the delta gap. So these are the various causes of acidosis and alkalosis you should know of. The causes of respiratory acidosis, COPD, asthma, increase in CO2 production, central causes, or there is a respiratory alkalosis in which there is pain, anxiety, hepatic encephalopathy, pregnancy, salicylate poisoning. These are the causes of your metabolic alkalosis, laxatives, vomiting, diarrhea, all these things. And this is the cause of your normal anion gap and high anion gap metabolic acidosis. So renal tubular acidosis, GI losses, or high anion gap metabolic acidosis like methanol poisoning, aspirin, renal toxicity, ketone body. So all these are the causes of high anion gap metabolic acidosis. Just a quick revision for the entire thing. Now we'll go to the questions. I request all of you to answer. Okay, first MCQ. How do you avoid an air bubble in an ABG sample?
Everyone, please write in the comment box. Only Hemlata is answering, it seems.
Somebody raised a hand also. You can just write in your comment box.
You can just write it down in the chat box.
So I think most of you know this answer.
Okay.
It's yeah, it's option B. So you draw it very slowly, and also you can use a glass syringe to avoid air bubble, but we actually don't have so many glass syringes these days in use. So the answer is draw it very slowly. We'll go to the next question. How much amount of heparin is needed in an ABG sample? This was also told in the presentation. So they're answering B.
Anyone else? Everyone, please participate.
So the answer here is C, not B or A. It is only 0.05 ml of heparin you need for 1 ml of blood. That's all you need. If you have more, then there will be some problems in the ABG, which we discussed. So uniced sample, how quickly will it become invalid? What's the answer? Uniced sample.
Yeah, so except one, everyone wrote A.
Yeah. So A is correct. So only 15 to 20 minutes you have to process an uniced sample. If it's an iced sample, it can still be 1 hour, but the answer is 15 to 20 minutes. What are the findings of a respiratory acidosis? Okay, very good. So I think most of you are getting this one right. So acidosis means pH will be low, and respiratory acidosis means CO2 will be high. So the answer is A. Very good. Okay. So interpret this ABG. You just have to write your answer. Okay. That what is the primary dominant disorder here and what is the compensation here. We don't have to know the adequacy of the compensation because I'm not telling you the formula here. Just tell what is the disorder and what will be the compensation. Okay. So I think that is right. So you have respiratory disorder here. Your CO2 is high and pH, though pH is normal, but it is respiratory acidosis. And there is some amount of metabolic compensation that is happening because bicarb is also high. So last but not the least, always remember, treat the patient and not the ABG. ABG is just a tool to help you, guide you. Okay, but don't base your entire treatment on ABG. Okay, treat the patient first. Okay. Thank you.
Thank you, Dr. Monalisa, for presenting this complex topic very simply and very nicely And I would ask our participants and all members, if they are having any questions, they can ask Dr. Monalisa or me. Himlata is writing, thank you, ma'am. Okay.
So, just always remember that once you take a history and physical examination of a patient, when you do, always find out if you do an ABG, always find out what is the primary disorder. That's all you have to see. And then you have to see if there is adequate compensation happening or not happening. Don't worry about the formulas. That was just a theory part to tell you guys that this is how we calculate if the compensation is happening or not. Okay. So that's all. And you have to know what are the values when you have to, immediately inform your doctor. What are the red S bar values, what pH is dangerous pH, and when you have to immediately escalate the situation and act accordingly. So always have a look at the ABG, identify if there is anything alarming, immediately escalate. So that is the whole crux of having this presentation for the nurses, so that they know when to escalate, what problems they face on a daily basis, while analyzing and interpreting an ABG.
Thank you, ma'am. Let's finish this session.
Okay, any doubts? I think we don't have.
We can close the session, I think. Yeah.
Thank you. Thank you, Doctor.
Thank you, Monalisa ma'am. Thank you, Paramita.
Thank you.
Yeah.